Hello, welcome to the Stella Life Innovator series. I'm Liz Lundry, and today I'll be talking to Kelley Richardson. And Kelley has worked in dentistry for over 25 years and is an author, a speaker, an influencer, and a nose breather. Yay! She's an orofacial myofunctional therapist and the founder of superbreathers.com, providing awareness to parents, caregivers, teachers, and medical professionals who can help identify and screen children presenting with the signs and symptoms of disordered breathing and restless sleep. And Kelley's the author of The Very Stuffy Nose, a children's book, which we'll share with you today, as well as the co-author of Chicago Heart's Patient, Parent, and Teacher Education Guide on Sleep-Related Breathing Disorder Phenotypes with Dr. Kevin Boyd. Welcome, Kelley. I'm so happy you're here today.
Thank you, Liz. It's a pleasure to be here.
Yeah, so tell us about your mission and your journey helping youngsters to breathe better. How did you get started with that?
Well, like you said, I've been in the dental industry for a long time, but I wasn't very much aware of what dentists were doing at the time when my son was born. And really, my son was born in 2011, so there wasn't really much being done evaluating airway and sleep and breathing at the time. So when I had my son, I didn't have a lactation specialist, and I didn't have all those people that can be very helpful. I just figured I'd wing it. And the first day, he wouldn't latch, and nobody had any ideas on how I could make that happen. We had lactation specialists at the hospital, but they didn't really offer anything other than to just kind of adjust my position and try this and try that. But what I found so odd is that it didn't seem like anyone had answers, but nobody seemed to be like offering any solutions. So I, at the time, figured this is just me. Something's going wrong with me. And I guess I'll just figure it out. I'll get my computer out and I'll start Googling it and see what I can find out. And ultimately what happened is we ended up just going to bottle feeding after a couple of months of trying to nurse. Yeah. But what resulted in the fact that that was very symptomatic of a child that has disordered breathing that led to disordered sleep, fragmented sleep, and all of the effects that can come from that. Yeah. So what I found was after 6.5 years of my son not sleeping through the night, we saw a lot of things in his, not just behavior, because he's always been an amazing kid, but he's always had a lot of energy. Wasn't necessarily able to focus or learn things as quickly as other kids. And so there were some things there that had I known, I would have really been able to get ahead of it. And thankfully I found out what was going on at 6.5. So we were able to catch it. But my mission really is to be that voice that I was looking for. And I just know that there's so many parents and teachers and caregivers out there, and even in the dental community that are looking to learn more on not just my journey, but what you can find in the signs and symptoms of children to be able to treat before 6. That's really what's ideal.
We're on the front lines as dental professionals to see what's happening and then provide some type of a treatment plan or refer out if we're not doing it ourselves. But we need to know what to look for. So this is so great that we can talk about this. So what have you found that we do need to look for, and what are your recommendations?
Okay, I'm going to throw up a couple of slides here because this will be able to cover a lot of information without taking too much time. So I'm going to share my screen. And really the common behaviors, the behavioral symptoms of sleep disorder breathing include, well, mouth breathing is a big one. So any treatment modality that you go down, once you recognize that mouth breathing, that a child has disordered breathing, either from a functional issue with a tongue tie or something restricting them from being able to effectively get their tongue on the roof of the mouth, that's what's really important. And so you cannot actually, you can even try this. Try suctioning your tongue to the roof of your mouth and breathing through your mouth. It's not possible. So a child that is mouth breathing definitely has a low tongue posture. That low tongue posture will fall closer into the back of the throat where the air is. And what happens is during sleep, when that lower jaw relaxes, and the tongue we know is connected to the lower jaw, as it falls back into that air space in the throat where you're breathing, the body will want the child to move or adjust to get that opening back up. And they don't generally tend to always close all the way off. It's just a little narrowing can signal move. And so for Finn, what was happening is it was a lot of move, restless sleep. And then he would wake up multiple times after a while. A lot of times out of frustration, could have been nightmares, because that can be part of it too. But just somehow he knew he was supposed to sleep through the night peacefully and comfortably, and he wasn't. Yeah. And that tongue, he had a tongue restriction, which we addressed at 6.5 once we were able to identify it. But the other behaviors that over here on the left of this slide, waking at night, restless sleep, sweating. Oh, he was a profuse sweater all night long and through naps, kicking during sleep, nightmares, night terrors. Some children actually see creatures, which is more of a night terror versus a nightmare where you're just having a bad dream. Difficulty learning and focusing, and that can be on many levels. So for my son, it was not, he seemed to progress well with others, but it took him maybe a little bit longer to learn how to ride his bike. And that's sort of like, when you're not connecting in the deeper sleep, what you learned that day, because you're not getting to deeper sleep, it can really start to add up as they get older. So that's why we really want to treat before 6. It can also look like, and then this list on the right side of the screen is also these are other symptoms too. He didn't have all of these necessarily, but he did have a lot of activity. I wouldn't really call it hyperactivity. Maybe I would, I don't know. But however someone would define that, ADHD, hyperactivity, chronic fatigue. He had a lot of energy, so it didn't look like he was tired, but he really was tired if you looked close. Habitual daytime napping, resistance to falling to sleep, bedwetting. That's a big one. He didn't have that, but it really, when children are addressed for specifically just turning them into a nose breather at night, then this bedwetting I've heard lots of stories about how that after a couple of weeks will actually stop. And that's because the body's system starts to shut down all of the systems so that you can go into REM, and instead of and having enough of that antidiuretic hormone, it will actually, they don't have enough of that hormone that says stop the liquid, so they'll end up bedwetting.
It's all
teeth grinding. I'm sorry.
It's all connected, isn't it?
It is. And most people, that's the thing. I think so many times you can have 2 or 3 of these symptoms and not have any idea that has to do with breathing, how they're breathing, and sleep. And some of these things you can kind of address on your own, and some of them you need a little bit of help.
Right.
So
some of the things on here, like the teeth grinding and the snoring, I know that through the years, because I've been a hygienist for over 40 years, and I have heard doctors telling the parents, oh, teeth grinding in kids is common, it's nothing to worry about. This is years back, so the awareness just isn't there. Also with snoring, people don't realize how dangerous snoring is and the problems we have with snoring that impact our health. Yeah. Starting from the time we're children.
You mentioned, so this is something I learned from Dr. Kevin Boyd. He's where we have our orthodontics done. So Finn, we take Finn to him, and he and I were able to work up, like what you said, of the phenotypes of disordered breathing. Actually, I'd seen that he had done that in a presentation, and I said, can we please make that into something that's accessible? And he was all for it. But what he said, and I think it's on my next slide here, is normal is not healthy necessarily. It's normal. Oh, it's normal that they teeth grind. Okay, is that healthy? It's normal that you're snoring. Is that healthy? And the truth is, we have normalized so many behaviors that are so common because when the tongue is not in the roof of the mouth comfortably, then it's not pushing that upper jaw forward. And so it's trapped back. And so just because it's trapped back and you're having some of these symptoms doesn't mean that we don't need to address that. Right. So yeah, I think you can see here. So I wanted to show a couple of slides. This is Finn. I can show you probably thousands of pictures of him with his mouth open and this recessed chin. So the tongue in the roof of the mouth is going to push this maxilla, this bone that houses the upper teeth up here forward. And when it's not there, then this bone doesn't come forward and we start to see some of the effects of that. But here you can see that his chin is so far back and his tongue was tethered enough to not be able to reach the palate, to not be able to effectively breastfeed. Yeah. So that is, we know that when you have a child that is not breastfeeding and you clip the tongue, if that's what's necessary, doing a frenuloplasty, a very simple procedure with a laser, it takes less than a minute, then these children start latching immediately, or it could be a lip tie, or it could be a cheek tie. So this painful, or in my case, just really lackluster breastfeeding where I'm trying all of these things. Had we addressed it at that point, he may have had his tongue suction to the roof of his mouth for his whole life, and we wouldn't have seen these sleeping issues that happen. And what I'm so passionate about is the mouth breathing is indicative of probably sleep issues, because that you're more likely for it to fall into the back of the mouth, back of the throat while they're sleeping. And for me, that's where you lose out on a lot of issues. So let me show you a couple of those. And again, is it normal that he couldn't latch? Is it normal that he was a mouth breather? Is it normal that he had enough energy to spend an entire day at a New York City playground with just a few breaks? I mean, that's a high level of energy that he was burning off from him being in sympathetic tone through the night. So he was this is his normal, but this is not healthy. Having speech difficulties with his letters, his R and his L, that's very common if the tongue is not properly learning how to swallow and function. And is it normal that he was a restless sleeper? There are a lot of restless sleepers out there, and people think that as long as they're not waking up in the middle of the night with their child, if those sheets are all over the place when they wake up the next day, then they're very likely a restless sleeper, which means they're probably not getting to those deeper levels of sleep. So in my case, like I was saying, Finn was he had a stuffy nose for a very, very long time. And what we know now is that mouth breathing leads to local inflammation. And that local inflammation can be enlarged adenoids, enlarged tonsils. But in his case, it wasn't that. In his case, it just created the inflammation in the nasal cavity that meant he continued to mouth breathe. So he was stuffed up for as long as he was alive, pretty much. And so I don't even know at what point he would have known to start nasal breathing until we definitively said, you are going to start nasal breathing. And he said, if this is going to make me sleep, I'm in. I had no resistance. That doesn't mean some kids won't be resistant, which is why we wrote the book. But in this case, I mean, I look at pretty much any year of his life up until 6.5, 7, and it's got an open mouth posture. Yeah. The problem is that with mouth breathing, it, like I was saying, it leads to nasal congestion and local and systemic inflammation. But it also, when you nose breathe, you have the benefit of the air being warmed, filtered, humidified. But also, more importantly, there's this, in the nose, you have a gas called nitric oxide, which is a vasodilator. So it opens up the blood vessels and lets more blood get to the organs in the brain and the systems. But it also is an antimicrobial and an antibacterial. So when you have cold and flu season, and there's a lot of stuff that's going around, if you're able to catch some of that in the nose and keep that out, there's nothing like that in the mouth. So there's a lot of ways where your nose is just protecting you. It's your first line of defense, and the mouth the first line of defense with the mouth is the tonsils. Right. And when they get larger, because they're collecting all this gunk, then it causes more problems. So, right. Yeah. So Christian Guimino is the one that sort of linked everything. He had years and years. He had 50 years. He's basically the leading authority on sleep medicine. And what he decided, he came to his consensus after 50 years of research, because this was in 2018, was that mouth breathing leads to local inflammation, leads to systemic inflammation. And you can see a lot of the other arrows here as well. But what Dr. Zoggy, who is a protege of his, and you and I both know him, we have a lot of respect for him, that what he realized is that before the mouth breathing, if you've got a restricted tongue, then you're going to have a low tongue posture. The low tongue posture is going to make it super easy to mouth breathe. And then now we start to get into the abnormal orofacial growth, because what we also know is that when you have a mouth that's open in a young child, their face will form longer instead of wider, and their dental arches will form more narrow. Right. And so you start to make it harder and harder for the tongue to get to the palate, because a narrow arch means a higher palate, which means the tongue has to go up higher. And then you could actually get to a point, if it's just a habitual thing, you get to the point where the tongue can't reach that until you expand it back out. So there's a lot going on.
It is. It's all connected there too. So getting that ideal posture with the tongue, which includes frenuloplasties, some therapy, and orthodontics. And I'm going through all that myself. I've had a frenuloplasty not too long ago, and I'm going through all that expansion too. So, but starting early with the kids, because we have so many kids that have ADHD. And they're being given prescriptions, and we know it's linked with this issue with breathing, this issue with sleep. They're not wanting to eat certain foods, all of these things. So, yeah, incredible.
Absolutely.
Yeah, important. Mm-hmm.
Absolutely. Well, the cool thing is like your story is that it doesn't matter what age you are. There are things that can be done now to help you get back on track, or to help address certain things that with expansion and orthodontics and all of that, it doesn't have to be addressed at this age. It's much, you can move the bones under 6. You can develop things in a different way, right, and you can help a child that way.
You can influence their growth if you start early, and that's really ideally what you want to do, so they never have these issues. So that's the best approach. Yeah.
Agreed. And so this is where we're talking about the tongue needs to be suctioned up here. If the tongue is here, it's still tied down here. And this is what would be called a posterior tie. I had this, so I could reach up here, but I couldn't reach up here. And this is what's going to pull most of the back of the tongue up and away from your airspace. And so that's what we're talking about. So even if you can get a little bit here, it's not a comfortable suction. And so when Finn had his frenectomy, or his frenuloplasty, my husband and I both had ours as well.
The family.
So, can be hereditary. It can be genetic. But the sleep stages, and this is what I'm most passionate about, is the first level of sleep. You're really just it's entry into the deeper levels. So, that's nice. You spend about 10, 15 minutes going through that stage, maybe less. But in this case, your N2 sleep is where you end up spending a lot more time, because if you have fragmented sleep. So the onset of sleep, the heart rate slows and the muscles relax. And in this area, if you can't get past N2 or stage 2, then you may be getting some of the benefits of the brain fortifying what was learned that day with physical and coordination skills. But what you're not going to get is restorative sleep, tissue growth, energy is restored. The brain takes these memories, such as the storage of facts and events, and it puts it into a longer term storage. So it puts it in the cerebral cortex, where it's making space for new learning, and allows you to be able to really contributes to insightful thinking, creativity, memory, and all of these areas where you really need your child being able to take what they learned, put it into longer term storage so that they can build on that. So when he rides his bike one day and he starts to get it, then he picks up on that because he's got that in long-term storage. It's not just stuck in short-term storage, and he has to kind of relearn it, and it takes longer to get there. But the hormones that are released are growth hormones. That's essential for growth and muscle development. So if you have a smaller child and they're running around a playground, they're a little more hyperactive, and they've got some of the venous pooling, and they have some of the white under the eye, you can see that. What that's indicative of is that the tongue didn't push this bone forward, and it's not allowing their tongue the space it needs at night. So you're stuck in this phase where you may be getting this fragmented sleep and not getting to the point where you're getting a lot of that growth hormone. You can get some of it, but you're not getting the levels. So you might start to see that in the third grade and fourth grade, you have the difference between the taller kids who seem well rested and tend to have a little bit more muscle development, and they tend to be really good at sports. Well, they slept well. So and you really can, if you look in a playground, you can really start to see that the difference between sort of the kids who are able to handle their emotions a little bit better, because you also start to get some of that emotional regulation there too. Right. So, and again, like I was saying before, the vasopressin, which is the antidiuretic hormone, which helps you keep from bedwetting. So like I was saying here, if disturbed, then the bedwetting, the parasomnias, the night terrors, the nightmares, and then the brain fog, because they weren't able to really layer their knowledge. They're just kind of, they didn't get to this level to be able to do that.
Yeah, they can't process things as they should. So yeah.
So then when we get to REM, that's where there's a restoration of the optimal emotional reactivity. So some kids that are having trouble with certain emotions and really just seem a little bit fragile at times, it could just be that they're having trouble that week sleeping well. Or it could be some that are having this more of a long term. It's just, all I'm saying is I'm not a doctor, and I'm not saying that this is the end all be all, but start with evaluating the sleep. And if the sleep isn't there and they have an open mouth, then that's where I said, okay, well, let's write a book and make sure people know that they should have a closed mouth. Let's kind of just address the general awareness. And then if there's a situation where it's just functionally or anatomically, or you have some barrier to be able to getting them to help them close their mouth, it's not habitual. Now we've got an anatomical issue or a physiological condition that we've got to kind of get some more help with. That's when we can reach out to others. But just knowing that mouth breathing is not your healthy route is where we started with the book.
Right. And how can we teach them? Because there's so little, and the book is a wonderful way to go about it.
Well, so for me, the book really was just about awareness. And so with Finn's story in the book, and what we did was we took the idea that Finn got a cold. So he was, it starts off where he remembers that he could smell things. And so we're going with the smelling because that's a little bit more something to connect with kids. But with the book, we decided that when he gets a cold, he opens up his mouth because his nose gets stuffy, and he opens up his mouth and he realizes he can get lots of air in, and that was great. So he breathes all this air in, and it's much easier because he had all this nasal resistance from his cold. And so after the cold was gone, he just continued mouth breathing. And so the whole idea with the book is that after about a year of realizing that he couldn't smell the hot dogs in the fall at the fall festival, and he couldn't smell the hot chocolate, and he missed the smell of flowers, and he even at the end of the book starts to realize he doesn't even mind the smell of stinky socks, because we get him back around to the fact that he thinks back to when he really was unable to start smelling, and that's when he had started breathing through his mouth. And so he then takes the 2 weeks, he takes the week, actually it's about a week time, and we kind of stress the fact that he has to remind himself, I'll keep my mouth closed and I'll breathe through my nose. And so it becomes this little mantra, I'll keep my mouth closed and I'll breathe through my nose as he's going to school, on the playground, every bit during the day, he's reminding himself of this. And then after about a week, he can start to really smell the scents that he misses. And that's the whole idea, is that his nose, he realizes that his mouth is for eating and drinking, but his nose is for smelling and breathing. So we wanted to keep it fun and kind of silly and simple for kids to create this awareness. But then at the end of the book, we talk about our story in the sense that what we realized is that his restless sleep and his nightmares and all of these consequences of mouth breathing kind of started with the mouth breathing. So we give the adult reader at the very end context so they can then use the book. And then we peppered with every 2-page spread, you're going to find one lizard. You're going to find a baseball or maybe multiple baseballs, and the cat is throughout the book. So I started off thinking,
it's a beautiful book. Let's take a look at that book and show everybody, because it really is great. And it's so user-friendly for these young kids, because it's just a beautiful book for, the illustrations are amazing. But like you're saying, it's kind of like a game. And when you look at it, you have all these animals that are throughout the book. And then there's activities where they have this nasal breathing tracker that also is a scented sticker. So they need to be able to be breathing through their nose to be able to appreciate that, which is genius, for you to do that. And they can track how they're doing. But it's fun and it works.
Well, I'll tell you, my illustrator is, I cannot say enough about my illustrator. He's not in the industry, and he's not a medical illustrator. He's an illustrator that just took my direction. And I said, I need venous pooling. I need scleral show, which is the whites of the eyes. I need the chin down and back. If you can see here, the chin that's down and back when he's mouth breathing. And when he's nasal breathing, we reverse all of those things back to where he was able to restore himself into better health.
You can see the transition through the book. It's really, really great, and just literally illustrates it. So it's just such a great tool for these kids, and to have families have some way that you can do that together. That's fun, because it can be really annoying to the child to get nagging going on all the time. So having it as a fun activity is the way to go. So as dentists and hygienists, we're on the front lines as we see our patients, where we can detect this. So how can we help these children? And, what resources would you recommend, and what action should we take when this happens in our practices?
Well, the dental community is really prime, especially the hygienist, because when you have a mouth breather, you're going to have a lack of saliva that is going to then lead to the potential for a lot more cavities, especially in these kids. So when you see a child that's has a lot of fillings, and it's, we're not, it can also be the amount of sugar that kids get these days, but really just starting to take a look at every single child that walks into the practice and looking, are they breathing through their mouth when they walk in, or when they're just sitting there? Can you hear them? Because mouth breathing is chest breathing. So I've taken the Buteyko breathing training so that I can understand breathing better. And when you breathe through your nose, it's quiet, it's diaphragmatic, it's helping your body functionally push more air into the lungs. But chest breathing is a lot more. So you can see the chest going up and down. You can see the mouth open. It could be, their gum disease, halitosis. Those are all symptoms of that. But what I would say is that not just physically keeping an eye on the kids that come into the practice, and adults, everybody that comes into the practice, I would suggest starting with a sleep screening, or fairest.org, FAIREST.org has a 6-point evaluation that dentists and hygienists can do. So it's not going to take a lot of extra time, but you can start to recognize, do they have mentalis strain, where the mouth is straining to keep the lips closed? Do they have, looking at the back of the throat, it's called a Malampati score, but it's how much of the back of the throat is already visibly, you can see how much of that is closed off. there's, I think mouth breathing is obviously on that list as well. So there's about 6 points that you can start to identify in your patients and do a quick screening. And then also having each patient do a sleep screen, an evaluation of behavior and sleep. And on our website, I believe we have the one from Dr. Kevin Boyd on there. So we have resources for doctors and for parents, because parents can screen their children too, and then go into their dentist and start asking about this. And if their dentist is not aware of sort of airway type messaging or understand that, then maybe they can ask for somebody, a myofunctional therapist in the area who can then
have myofunctional therapist to which to refer in the area. And then you have that team that's a great referral source for you as well. But it just, I do that as I train hygienists and teams, which I also do to include the Mallampati score as well as checking for tongue tie. I mean, you can do this in just one quick look. And then of course, if you're spending time in that patient's mouth as a hygienist, as a clinician, you can see everything. And we just need to be looking out for them and then talking to the parents and giving them options, which on superbreathers.com, you have some great resources there. So
we do.
You can check that out. And there's also a link to be able to order this, which if you have a pedo practice, you may consider having these, or even whatever kind of practice you have kids in your practice, you can have these available to educate them and to really help them. And it will be a wonderful reference for them too. So I think that what you're doing is so terrifically important. We know that there is an epidemic of a lack of sleep all over the world, and it leads to poor health. It's linked with diabetes, heart disease, definitely with dementia, Alzheimer's, and it all starts when we're babies. And we need to help educate, and as healthcare providers, if we're not sleeping and we're not breathing, nothing else we do really matters. So it's
exactly.
It should be on the forefront of our to-do list every day to really impact people's lives as you are doing. So Kelley, I really want to thank you so much for sharing this information with us. I'm inspired again, and I'm so happy that we have someplace else so we can really get help, specifically for the kids, with the book and all. So congratulations on the book, and thank you so much.
Yeah, well, thanks for having me. And it's really great to partner with other organizations who are definitely looking out for our well-being. And that's what I love so much about Stella Life. So thanks for having me. And it was a pleasure.
Together, we're here to change the world, as all of you out there too listening today. That's what all our mission is, right? So thank you for everyone's time today, and come back next time. We'll learn something new from an amazing innovator like Kelley Richardson. Thank you again, Kelley.
Thanks, Liz.
Thank you.